COVID-19 Response Working Group. It's Thursday, April 2nd, 2020. I'm going to read some opening remarks and make a few comments, and then we'll go from there. But thank you. This is an opportunity for us to reach out to the public. The media can look in on this as well. It's our first attempt, or most recent attempt, to use technology and try to be transparent as well and gather information from the public. So good afternoon and welcome to the first hearing of this Minnesota Senate COVID-19 Response Working Group. This group was formed to review and discuss the state's response to COVID-19 and to vet requests by the governor and proposals by the legislature to address COVID-19 needs and resources. The working group will also be able to review previously passed funding and bills to provide oversight. As a working group, there are no votes expected. Our intent is to utilize online resources to make COVID-19 discussions available to the public. We hope to find opportunities for testimony from public, expert witnesses, and stakeholders, and document the engagement between senators as we review bills and proposals to address the COVID-19 threat. The working group is comprised of 11 members, and I will serve as the chair. In addition to me, Senator Benson, Chamberlain, Champion, Cohen, I'm sorry, they've got a typo here, Champion, Chamberlain, Kent, Marty, Pratt, and Rosen. If I missed somebody there, let me know. We will also have one rotating member from each caucus on the group. They will be added to the working group during designated meetings to provide additional input. It's clear that these times require focus and speed. Establishing this working group gives the Senate a place to discuss the state's current response and future needs. We are being careful to follow our state's shelter-in-place requirements, and we're holding this first hearing using the technology provided through Zoom. This is the first time we're attempting this while live streaming through Facebook and YouTube so that the public may observe. I ask for your patience if our technology and abilities aren't our usual professional quality. Members have provided with some basic instructions as to how this will work. All participants will be muted during the hearing. So with that, I want to begin and turn this first section over to Senator Michelle Benson. So Senator Benson, are you ready?
Hi, good afternoon, everyone. As chair of the Senate Health and Human Services Finance and Policy Committee, I have gotten a unique look at what our healthcare system is doing as we prepare for the COVID response. And I wanted to take this first meeting to talk about what our hospitals and our long-term care system are doing. And so we have some key people who are going to be giving public testimony. Mary Krinke from the Minnesota Hospital Association, Corey Brown from Sanford Health, Rebecca England from the Minnesota Emergency Nurses Association, Mary Turner from the Minnesota Nurses Association, and then for the long-term care portion, Dr. Emily Downing of Allina Health. And so let's begin. I invited Mary Krinke from the Hospital Association to start the presentation. So I'm watching for her video to come up. So just a few comments while we get Ms. Krinke online. As the world faces a COVID pandemic, Minnesota's healthcare systems have been preparing, ready to perform. We have a nation-leading healthcare system, and we have the talented leaders who are going to help bring us through this epidemic. The legislature can provide funding and support, but there is no substitute for the work that the men and women of our healthcare system will do on the front lines. Preparation in our healthcare system started long before COVID was a regular part of our everyday vocabulary and news. So today, we're going to hear about cooperation between our hospitals, nursing homes, our healthcare providers, and other caregivers as they prepare for what is to come, both here in the Metro and in Greater Minnesota. We know that nurses are critical on the front line, so we're going to hear from them. We know PPE is a concern, and I'm sure that will be raised as we go forward. But with that, I'm hoping that Ms. Krinke is ready and available.
Can you hear me?
We can't see you, but we can hear you.
Okay. I don't know if their staff is going to see it so you can see me, but that's okay. I'll get started. How's that?
Please do.
Okay. First of all, I'd like to thank Senator Gazelka for the host has asked you to start video. Okay. There.
There we go.
Okay, great. Hey, it's great to see everybody. So thank you all. My name is Mary Krinke, and for the record, I'm with the Minnesota Hospital Association. And I'd like to start out by thanking Senator Gazelka for forming this COVID working group. I do think, sadly, that this may go on for some period of time, and we don't know if there's going to be a need for you all to discuss future policies over the legislative interim and into the fall. So having this working group in place with bipartisan participation, I do think is very important. So thank you, Senator Gazelka, for your leadership in forming this working group. I'd like to start out by saying that, and I know you all know this, the challenges to our healthcare system right now are going to be enormous. We are likely to face shortages of staff, resources, materials like ventilators. And I also want you to know, while this is going on, our hospitals are working around the clock in order to acquire the necessary resources for this pandemic. So I've developed an outline of several topics that I'd like to share with you today to provide some background that I think would be helpful. And I think it would be good for me to at least mention the 5 areas that I want to touch on so you can follow my outline here. So the first one I'd like to talk about is the emergency preparedness structure that is in place, our testing challenges, the stay-at-home policy and modeling, what our hospitals are focusing right now on spaces, supplies, and staff, and then some information on hospital financing. I think those 5 topic areas would be helpful for this discussion today. So the first one is the emergency preparedness and the structure that is in place. As some of you all may know, we have had 8 healthcare coalition regions around the state. This has been in place for some time as part of our state's emergency preparedness. They're in all corners of the state. No surprise, they're in the northeast, northwest, the central part of our state, the south part, and a metro area. These 8 area coalitions are reporting into, and I hate to use abbreviations, it's the SHCCC, and that stands for the Statewide Healthcare Coalition Coordination Center. And that is being manned by the Minnesota Department of Health, these 8 regional coalitions, as well as the Minnesota Hospital Association. And that work is also in conjunction with another abbreviation here, the SEOC, and that is our state's Emergency Operations Center. Now that is involves the National Guard as well as members of the Walz administration and the various agencies. So these 2 organizations are working hand in hand with each other. I am pleased to report. I'm pleased to report that.
I've got the sound. I can't get into it though.
Okay. I'm pleased to report that right now, Dr. John Hick is serving as the chair of this. Is working pretty well through these organizational structures. They are working right now to get a handle on what our current resources as well as what we project will be needed for the surge. So they are working right now to get input from all the healthcare providers regarding what resources they have and what we think the surge capacity will be. Before I get into what the hospitals are doing, I'd like to talk about a couple other challenges. And next in my outline was testing. Yesterday, the Minnesota Department of Health reported that we had 689 confirmed cases of COVID with an uptick of 60 cases yesterday. But this is probably greatly understated. Because of our lack of testing, we probably have thousands of additional Minnesotans who have COVID-19, but we don't have enough tests available to do the necessary testing. So we have several of the hospitals that are capable of doing this testing. Hennepin County Medical Center, Fairview University, Mayo. There are others that are can do this testing, but there is a lack of testing supplies, the reagent, the swabs, the personal protective equipment. I'd like to say that all of these supplies are on back order. We are pushing our congressional delegation weekly. Once a week, we have a call with the Minnesota congressional delegation. This testing issue has been top of mind. We need the materials in order to do broader testing in our community. We believe we are greatly understating the number of cases that are out there. Currently, we are testing 3 groups of individuals. Number one, and very important, are healthcare workers. We believe that healthcare workers should have access to testing. Number 2, individuals that are already in the hospital with COVID symptoms. We need to confirm that they do indeed have COVID. And number 3, individuals living in long-term care facilities. So those are the 3 priorities for testing right now. We're hoping that testing can be expanded. The third topic that I would like to talk about today is the state's stay-at-home policy and the various modeling. As you all have seen with the national media, the goal here is to flatten the peak as much as we possibly can, as well as push it out. If we can push the peak out into the future, this will give us more time as a commodity here, for us to stabilize our supply chain, whether that be getting more personal protective equipment into Minnesota, more ventilators into Minnesota. We want to flatten the peak and push it out. So there are a couple different models. The Department of Health is using a model that is basically a public health model. And I want to say these models are not in conflict with each other. It's like looking at 2 sides of a coin. Our members are using a model that is more operational in nature. It is to help them on an individual basis look at what their own bed needs are going to be, staff needs are going to be, and supply needs are going to be. These models are not in conflict. They just look at the issue differently. And why is modeling important? Well, it gives us kind of an idea of what we think are going to be the supplies and resources that we need, and when is that peak going to hit. So those are kind of sort of unknown variables, but we all believe that it is better to over-prepare rather than to under-prepare. So that has kind of been the focus of these different models. The Department of Health reports that our social mitigation efforts have probably pushed this peak out into the future, so it is helping. The time that we have now to prepare is very important. So we think that is helping to make a difference. I'd like to talk next about what the hospitals are working on, and I call this our 3 S's: space, supplies, and staff. So first with space, our hospitals are aggressively looking at how we can remodel, reconfigure, use any space in the hospital that we possibly can. We believe, and this is backed up by the healthcare experts, the best place to care for a COVID-19 patient is in a hospital. Now, that doesn't mean that we shouldn't look at alternative care sites, and that is going to be the job of the SEOC, that State Emergency Operation Command Center. They have other people that are looking at the alternative community space. We believe our role as hospital leaders is to try to expand as much capacity as we can within the hospital. This is where the supplies are. This is where the beds are. This is where the vents are. And currently, this is where staff is located. So we are doing everything we can to maximize the amount of space available for either a med-surg bed or an ICU bed. So that is our goal. We are working with the state's Incident Command Center, and we are reporting now what we think our surge capacity can be. We have this in 2 phases, a phase 1 that we think we can ramp up pretty quickly, and then a phase 2 over the course of the next month here. So depending on when you think the surge will hit, we will have more ICU beds available. But that is primarily what the hospitals have been working on, is to maximize the space available within the 4 walls of a hospital. We believe the department will have that information available to anxious policymakers soon. And I would just want to reiterate, the hospitals are not making the decision about the alternative care available potentially that will be needed outside of the hospital. Our job is to maximize the space within the hospital. The next issue that I'd like to talk about are supplies, both the personal protective equipment and ventilators. So we know that our number one job with personal protective equipment is to keep our workforce safe. If we lose the battle on keeping our workforce safe, we've lost a lot of effort in this fight. We know from California's experience, they had a hospital where nurses were exposed and 200 nurses were kept out of the workforce for 2 weeks, 14 days period of time. We have to protect our healthcare workers or we're going to lose this fight. So our number one goal is to make sure that we have enough personal protective equipment for our workforce. Yesterday, President Trump announced that the national strategic stockpile was nearly depleted. We have learned today that we do have an order in with FEMA, the Federal Emergency Management Agency. So we're hoping that Minnesota will get some of the shipment of personal protective equipment. This remains a top priority for the Minnesota Hospital Association to get as much PPE as we can. I'm going to be talking about finances toward the end of my presentation today, but I need to stop here and let you all know that the Hospital Association urged Governor Walz, at our encouragement, to issue the executive order to eliminate all elective procedures, outpatient procedures, and anything that was not medically necessary that was not related to COVID. This is coming at an enormous cost to our hospitals. It was a tough policy choice that we felt we had to make in order to conserve personal protective equipment. We urge the Department of Health, if there is an ask that I'd like to make from the Department of Health today, we urge the Department of Health to issue clear and concise guidelines on the use of personal protective equipment so that all of our hospitals are doing it the same way. This is guidance that needs to come from the Minnesota Department of Health. One of our members shared with us their policy, which I think is a good one, but has not been necessarily adopted statewide. This was that N95 masks, which is the better quality, should be used for emergency departments, ICUs, and COVID-19 cohort units, and that the standard ear loop cloth masks that you see people making and volunteers making those cloth masks, they should be used by all other staff. And we need sort of consistent guidelines in order to preserve our personal protective equipment. One of our members said, and I wrote this quote down, "Please treat the N95 masks like they are gold." We need to save those N95 masks for our frontline healthcare workers who are dealing with COVID patients. And I am sure later today you will hear from Mary Turner from the Minnesota Nurses Association, who will probably echo something very similar to that sentiment. We asked the Minnesota Department of Health to also be more transparent with us about what is available in our state stockpile. I think some of our members have felt a little bit of frustration not knowing what we really have here in Minnesota. What is our available amount of resources? We have, and I say we, I mean the incident commanders over at the Strategic Command Center, they have developed a burn rate calculator, which all of our members are now using to look at the number of patients they have and how quickly they are burning through personal protective equipment. So this calculator should help us determine in the long run what we think we need to take care of COVID patients. The last issue that hospitals are dealing with is staffing. And I just want to remind folks that we can build out capacity. You can look at alternative care sites, but if you don't have the staff to take care of patients, the rest of it really doesn't matter, okay? So staffing is going to be crucial in this. The number one goal, as I mentioned, is to keep our current staff healthy. I'm now going to go into a few areas that are a little controversial, okay? And I want you all to know that these are very unusual times, and we kind of have to put politics sometimes on the back burner. So I'm going to present some ideas for you all for your pondering and consideration, either through legislative action or through executive order. Number one is the issue of licensing. We need to streamline and eliminate much of our state licensing process so that we can bring in any healthcare workers from around the country into Minnesota. If you have a if you are duly licensed as a doctor, nurse, respiratory therapist in another state, we should allow our boards of nursing and boards of medical practices to verify that you are indeed a licensed healthcare professional in good standing, and you should be able to come into Minnesota within 24 hours. We need all hands on deck, and there are float pools of healthcare professionals who do not want to go to New York, who do not want to go to California, but they are willing to come to Minnesota. So I urge legislators or the executive through executive order to do that quickly. Now, these other issues are somewhat controversial as well. Physician assistants should be allowed to provide medical services without supervision if it is in their area that they are trained. Greater use of physician assistants. Number three, care providers should have immunity from civil liability for any injury or death that is a result of an omission, not a commission, but the result of an omission by a provider in support of the state's response to COVID. Students, medical students and nursing students should be allowed to work side by side with a counterpart if that adds more manpower. We'd like to ask that providers be relieved of any unnecessary record keeping. We think that retired nurses and retired physicians should get their licenses renewed, and that a great position for them would be to work in telemedicine. They may not be as retirees strong enough to work on the front lines, but we can use their expertise in telemedicine, retired nurses and retired physicians. We'd also like to ask for temporary relief from the Minnesota Health Records Act, particularly regarding treatment. We need to be able to share information with other healthcare providers in a timely manner. The last topic that I'd like to bring up today is the topic of hospital financing. Hospitals have been hit with what we're calling the quadruple whammy. Number one, hospitals already had low operating margins. The median operating margin for hospitals prior to COVID was 1.7%. So hospitals were operating with very thin operating margins around the state. Number two is the expenses associated with COVID. This moving around and creating more space, buying personal protective equipment, ventilators, it all has a big cost. So we are expending a lot of money right now for COVID. The third one, as I mentioned, was this shuttering down outpatient services, the elective surgeries, all labs, all unnecessary procedures. We have been working with Clifton Larson Allen, the CPA firm, and getting input from our members. Our hospitals right now in Minnesota are losing $31 million a day. $31 million a day because of lost revenue from eliminating elective surgeries. Now, like I said earlier, we made that decision because we had to keep as much personal protective equipment as possible, but this is causing enormous financial hardship for hospitals. And the last one is the stock market. We're not unique, but several of our hospitals have bond covenances for money that has been borrowed in the past for building projects, and they are very nervous about whether or not they'll be able to pay off those bonds. So I just would like to share a little bit more from a rural hospital's perspective. About 70% of their revenue comes from outpatient services. We asked one of our hospitals to run some of their numbers for us. Surgical cases are down 92%. Clinic visits are down 45%. Hospital censuses are down 50%. So I just want to share with you, for rural Minnesota, they're probably not going to be taking care of as many of these COVID patients. So they're basically pretty quiet right now. What we think could happen in the future here, as hospitals with the ICU beds fill up with COVID patients, our rural hospitals may be asked to care for other patients that are then moved out to rural settings. So we might be moving patients around to different hospitals as more care is needed. I'd like to mention the money that has been appropriated from the state. And I know that the Department of Health is extremely busy, but we are getting a little frustrated that the first $50 million that was allocated for the emergency pool money, none of that money has been sent out the door yet. So we're hopeful that the Minnesota Department of Health will quickly do this, but so far none of that money has been sent out. The remaining $150 million that is through grant processes, the grant application has not been posted. So let me repeat, since you all spent $200 million to help healthcare workforce and healthcare ambulances, hospitals, and other healthcare providers, none of that money has been spent yet. So we are very anxious to get that money out the door. We believe the sooner we can get that money in, the sooner we can help with staffing and other expenditures that are being made. I also want to make one comment about the federal money. We know that the CARES Act spent $2 trillion and $100 billion was allocated for health care. We are very nervous that Minnesota will not get its proportional share of that money. We are nervous that the hot spots around the country where COVID has already hit very high points, New York, Louisiana, Detroit, California, Washington State. We are very nervous that those states will get a disproportionate share of the resources. We are urging our congressional delegation to fight for Minnesota and see that we get our percentage share of that money. We don't know when that money's coming, which brings me to an idea that I know we may not be ready there yet, but I did mention this to Senate Finance Leader Julie Rosen the other day, that we could actually benefit from a loan program for Minnesota hospitals. The money could be paid back next year on a timetable, but we are in desperate need of cash to keep some of our hospitals open and operating. I'd also like to mention one other bill that I know Senator Rosen is working on, and that is we're urging legislators to pass a streamlined prior authorization bill. We believe that passing that bill would help add efficiencies to our system and allow us to care for patients in a more timely manner. I would like to end my little presentation today where I started, and that is that we do have a good structure here in place. We're working well with the Walz administration. We're working well with the Department of Health, and this Incident Command Center has some really smart people. So I know that Minnesota is in good hands, and I next want to really thank you all as partners in this. In a very short period of time, you all have passed 3 legislative bills under very difficult circumstances. The first $20 million was for our Minnesota Department of Health. The second bill was $200 million for our healthcare infrastructure, ambulances, nursing homes, and hospitals. And the third bill you just passed, voting and staggered voting away from the Capitol, and that was a bill for $330 million for our community resources like homelessness and food banks, and for additional resources for the state. So within a month's time, the Minnesota legislature has responded with $550 million to address this COVID crisis. So I just want to thank each of you all personally for the work you're doing. And I truly believe that we are stronger as we partner together on this. So thank you very much. And I'll be around for the other presentations. And Senator Gazelka, if there was an issue that I went through pretty quickly, I'd be happy to answer any questions.
And Mary, we're going to move to member questions. We have about 10 minutes for member questions. So members, I don't know if you know how to raise hands on Zoom, but Bailey will be monitoring. And then if you don't know how to raise hands on Zoom, just raise your regular hand and Bailey will make sure you're unmuted. And Mary, I think you can hear everybody as their mics are unmuted. So.
Okay.
I see Julie Rosen has a question and Scott Jensen has a question. So those are first two on my list.
There she goes. Okay.
There we go.
I don't know how to raise my hand otherwise, just by that way. A couple questions, Mary. Thank you. Very good presentation, by the way. Very succinct and very informative. I thought once in one of the original presentations that we had 2 million N95 masks in storage. 2 million. I'm sure I saw that in the presentation from the commissioner. And my other question is, we have idled healthcare workers in Greater Minnesota, and how do we utilize them? I just had my first virtual telehealth visit with my doctor yesterday, the doctor who birthed all my babies. It worked very, very well, and he is very concerned that we are not getting to patient. Nobody wants to come in to the clinics, to the hospitals, because they're afraid. They're not taking care of themselves. Their medication's running out. You know, just primary basic healthcare needs are not being met. How do we keep pushing this telehealth presence? Because it can work. It can work in healthcare. It can work in delivering mental health services. It can work in our schools, and we are falling short. A lot of people don't understand how this is working and how we can make it work. So a lot of questions there. The first one was the N95. I thought we had 2 million in stockpile.
Ms. Krinky?
Thank you, Senator Benson and Senator Rosen. I think there were sort of three questions there. So let me answer the first one regarding masks. Most of our hospitals now have developed a policy of one provider, one mask, one shift. So they are going through the N95s fairly quickly if you have one mask, one provider, one shift. I have not heard that 2 million a number, but depending on how many patients you have and what your burn rate is, you could go through that fairly quickly. So that is one of the asks we have of our Department of Health right now, because we don't know how much we have in supply.
Right.
So that is a question we have for our Strategic Incident Command as well as for the Department of Health. Regarding moving workers around, one of the executive orders that has happened that we were very appreciative of is the issue of background checks and fingerprinting. Prior to that executive order, if you worked at one hospital, say in southern Minnesota, and you wanted to come to a hospital in the Twin Cities, even if you were a licensed professional in Minnesota, you had to get a new fingerprint. Well, these fingerprinting centers around the state are closed. So one of the things that's in the executive order now is that you shouldn't have to go through an additional fingerprint. So we do need to use our current healthcare workforce to the best of our abilities. So agree with you on that. The executive order regarding fingerprinting should help. Regarding the third issue on telemedicine, total agreement. We've gotten very good support from, this is one area the federal government has been good on, and that is expanding telemedicine for Medicare. The state is working on, through the waivers, expanding it for Medicaid, and we've been pushing on the health plans to expand it for private coverage as well. So we've got the Medicare piece in good place, working on the Medicaid, and we could use a little help from the health plans on the private insurance part of it.
I thought we passed that in the last bill.
We did, but it's just getting, that was for equal pay, but we still have to sort of encourage more people to feel comfortable using it. One of the things that was in the waiver is to allow direct phone conversation for our elderly population. They may not be able to navigate an iPad and be able to use a video conferencing. So being able to have telephone to telephone would be helpful in telemedicine right now. We need to do a better, that's something that the hospitals could also do a better job of, to be honest. We need to promote that is an available option for people who need particularly clinic services as opposed to inpatient hospital services.
Thank you.
Mary, can you hear me?
Yes, Senator Gazelka.
Good. I just want to make sure, just a couple of comments and then a question related to, we invited the Minnesota Department of Health to be on this call, but apparently they had a scheduling conflict, so we don't know exactly why. But can you tell me, first of all, that $50 million that hasn't been released, what would you release it for, just so we have some ideas?
That was part of the Senator Benson's legislation with Representative Liebling. That was $200 million in funding. They broke it up into two buckets, $50 million in the first bucket and 150 million in the second. The first 50 million was to be in an emergency pool to get out the door quickly. And I know they got more requests in for the money than there was, but make some decisions and get the money out the door. I mean, obviously, I have bias that I think hospitals should get the money quickly, but even if it's to ambulances or nursing homes, they have needs too. But they need to prioritize that and get it done quickly.
Okay.
Okay, and
Thank
then
you.
one more question related, a different question, different subject, but and first of all, thank you for all the folks that are working at the hospitals. They're on the front lines, making a difference. They're going to make a difference in Minnesota as it surges. But there's been some conversation about whether or not they're covered under workman's compensation. We're working to clarify that, but I want to hear from you, your thoughts on that.
Yes. There's been a lot of discussions and negotiations back and forth. I've had telephone calls with several senators about this issue. The Hospital Association is supportive of doing presumptive eligibility for healthcare workers who have had direct contact exposure with COVID patients and have had a positive COVID test. We had two sort of requirements there. The original language that was sent to us from Dolly said that anyone who works in healthcare could be eligible for presumptive eligibility. Hospitals employ 200,000 people. We have many healthcare workers who work in billing, who work in collections, who are delivering babies, who are taking care of heart attack patients. So it's not that they couldn't get workers' comp, but we can't assume they should get presumptive eligibility under workers' comp. We are willing to say that if an employee, a nurse, a doctor, a respiratory therapist, if they've had direct contact taking care of a COVID patient, then we can assume if they got COVID-19, it was probably through their work experience. I've also been in conversations with SEIU, and they've asked me, well, what about janitorial staff and food staff? And I've talked with SEIU, and we said, hey, if they were going into a patient's room or into a patient's unit delivering food or cleaning a room, my gosh, a staff person who has cleaned up a room after COVID, they are maybe more likely than even a healthcare worker to get it because they're dealing with cleaning up the room afterwards. So what we wanted to do with presumptive eligibility is to narrow it to those employees where we can assume they got it at work. Also, we wanted to have a positive test. It's not just fair to say if you have a fever or don't feel good one day that you have COVID. We needed them to have a positive COVID test. So the Hospital Association is supportive of passing a work comp agreement that has been worked out between labor and the chamber. We recognize the work comp advisory committee process. And so we're hoping that those two entities can reach an agreement, and we would be supportive of that.
Yeah, thank you. I think we're very close for firefighters, police officers, first responders, people that you've described. I think all of us agree that they're on the front lines. We should be making sure they're taken care of.
And if I could, back to my list, Senator Jensen, then Senator Marty, and Senator Hayden. So Senator Jensen for Ms. Krinky.
Thank you, Madam Chair, and thank you, Ms. Krinky, for your presentation. Ms. Krinky, you mentioned that the average margin, hospital margin, operating margin is at 1.7% or so, and then you gave an overall view of what's happening to a lot of the rural hospitals. Then you went on to talk about the fact that there's a very good likelihood that the rural hospitals, outstate hospitals, have a good chance of not really being pressed hard even during the surge. They might be asked to take patients that would otherwise potentially be in metropolitan hospitals. What are we going to be able to do to help keep those hospitals alive? I mean, I sometimes have a concern that the Minnesota Hospital Association speaks more for the metropolitan hospitals than it does for the outstate hospitals, and I understand that. I do. But it seems like there's just nothing on the horizon that's going to help these outstate hospitals. And I think that when we get on the other side of this crisis, I think a lot of those hospitals are going to have a hard time opening their doors ever again.
Ms.
Senator
Cranky.
Jensen, I want you to know that twice a week, the Minnesota Hospital Association has a call with all of our rural hospitals. We brought up the subject of whether or not we should ask them to agree to the delay and postponement of elective surgeries. And they were fully endorsed this policy, recognizing that in the short term, it was going to cause them financial hardship. They recognized that the pull and the tug on personal protective equipment, that with until we can get the supply chain stabilized with manufacturers, we hope 3M is working 24 hours a day. We hope that the manufacturers of personal protective equipment will increase the supply. Once we can get the supply chain stabilized, then maybe these draconian actions can be lifted. But for now, they recognize that was what was needed to save lives of individuals and to save the lives of our workforce as well. So could they do what Senator Rosen said today about, maybe more telemedicine? Maybe there are things that the rural hospitals can do that don't involve the need for the PPE. So I appreciate your comments. I'm hoping that we'll have something from the federal government and money that can help keep our rural hospitals afloat in the long run.
Follow-up question, Madam
Senator
Chair.
Jensen.
Thank you. So, Ms. Cranky, just to be absolutely clear for the record, you're telling me that the outstate hospitals were consulted in making the decision to mandatorily prohibit elective procedures and that the outstate hospitals were fully on board?
I can tell you that they were
Ms.
fully
Cranky.
on board. Now, was there discussion and was it unanimous? Did we take a vote and ask them unanimously to submit their vote unanimously? There was some pushback, but we did have this discussion and they did agree. Yes,
Okay,
I can tell you
Senator
that.
Jensen.
And then just so everybody knows on this call or on this working group, the DRGs for Medicare for a non-ventilated COVID-19 patient will be approximately $13,000. And what that means is if a hospital has a COVID-19 patient that's not ventilated, cared for, whether it's 5 days, 10 days, or 15 days, the amount the hospital will get paid is a fixed amount. It's called a DRG, a diagnostic related group sum. That's $13,000. COVID-19 patients, as a general rule, probably end up spending, if they're not ventilated, 10 days in the hospital is not unreasonable. Hopefully it's less. But that's $1,300 a day is what they're going to get from Medicare. If the patient is ventilated, it goes from $13,000 to $39,000. The $39,000, hospitals can make money and there's margin there to do some of the other things they do. Once again, in these situations, the rural hospitals are going to have very few DRG submitted billings to Medicare, whereby they would receive $39,000. So I think the outstate hospitals are again going to be powerfully disadvantaged. And I really fear that we're just not really attending to keeping that part of our healthcare system open. I have grave misgivings about some of the things that we've inadvertently allowed to happen.
Thank you. Anything to comment, Ms. Cranky, or should I move on?
I want Senator Jensen to know that I actually really appreciate his comments because I share that concern as well. We just didn't quite know, how until we resolve the personal protective equipment issue, how else to deal with it. I mean, it's very tough. These are not good. These are not good options. Okay, we are picking between bad options. It's a bad option over here, and it's a bad option over here. So I don't make light of this. I really think we might need a save rural hospital legislation. Okay, that is something that I've been pondering. So I don't disagree with your premise.
And
To that
Senator
point,
Rosen,
Madam Chair,
to
thank
that
you.
point? Yes.
Yep, because I served and raised our children in Martin County, which has one of the highest 29 cases right now, 3 deaths in this county, in one county of a population of no more than 15,000 people. It's crazy. I think that's where we should have a serious look at Ms. Krinke's thought of a loan program. And whatever that is entailed, we should really drill down to see if the federal funds do encompass a rural hospital loan program, something like that, or if we have to do some state funding in that direction. But that's absolutely, you lose your basic health care, you might as well just hold up Greater Minnesota
Yeah.
out there.
And Ms.
And
Cranky?
I would like to propose to you, our biggest fear right now is the federal money might be in 6 months. So
Okay.
it may come trickling in later. So I've thought about, do we come back with another legislative ask? And if things stabilize, have the hospitals repay that money in 2021. But if we could get cash into our hospitals now to help with payroll and help them sustain the next 6 months. So,
Okay, thank you. I'm going to try to get back to my list.
yes, I'm
Senator
sorry.
Marty and Senator Hayden. No, I understand. I just want to try to keep on track. We have a hard stop at 2:30. So Senator Marty.
Thank you, Madam Chair. Ms. Krinky, first I want to second what you said about prior authorization. We should not be having other people who are not medical professionals telling doctors and what's going to happen. We're in a crisis now. We got to do that, and I hope Senator Rosen's bill will help get at that. The next one, personal protective equipment, I think is one of the biggest disasters that's causing this crisis to get worse. The one comment I would have about that is I've heard from a lot of staff in hospitals, nurses, doctors, and others, that they feel they're being left out of any of the decision making. I understand hospitals don't know this, but not meeting with them and so on. I heard one just last week, late last week, like Friday, of a nurse anesthetist who was bringing in her own N95 mask. She says she's poking in the mouths of patients, and she was not allowed to wear it because it was disturbing other healthcare workers that might scare them off. In any case, my pitch on that would be that the hospitals do meet with their medical professionals, talk with them, and make sure they're aware of everything the hospitals are deciding. That's just a pitch to do because I think the mask shortage is a crisis and I think we have to get at it. But the more the people who are doing the work, the frontline workers, understand why and what and have a say in it, I think it's going to work better. Then I do have a couple of quick questions, one of which is what are you doing to try and protect family members of workers? Do they have showers available at the end of the day? Do you have scrubs or uniforms or something for them to put on the beginning of their shifts to take off at the end so they're not dragging home infected clothes? What's being done with that?
Ms. Cranky?
Thank you. Senator Marty, every hospital has different resources on site and different resources that they're able to use. I know one of our health systems is actually paying for hotel space so that their nurses can go shower before they go home. Not all of our hospitals have the resources to be able to do that, to pay for hotel space for nurses to shower before they go home. Other hospitals have limited showers on site, and they are encouraging their staffs to shower, if you can believe this, sort of like in shifts in order to do that. I've encouraged our hospitals to accelerate their laundry services. They have contracts with laundry services that are washing the scrubs. And actually, we had to work on getting, if you can believe this, linen supplies to be considered essential workers for childcare. And if you had asked me, do linen supplies need to be essential workers for childcare? But the answer was yes, because we need to get more scrubs so that our nurses and other healthcare professionals, if they want a clean set, they can wear a clean set home. I don't want this to sound like I'm blowing your question off, but it really is a local question between what are the resources in that hospital, what are the resources in the community, but probably the hospitals need to do a better job of at least communicating with their staff what they're trying to do. Doesn't mean they're not trying to do things, but do their staff know what they're trying to do? So some of this is both a resource issue as well as a communications issue.
And then, Madam Chair,
Senator
one more
Marty.
question. I appreciate your answer on workers' comp and what you see how we should treat what's presumptive and so on. I'm wondering about when workers do get right now, if they are infected, are they using sick leave? Are you paying them? Because you want them to be staying home if there's any risk. What's the situation? How are you treating that?
You
Ms.
know,
Cranky.
thank you, Madam Chair. I'm sorry. Senator Marty, I don't have a very good response to that question. I think our hospitals are probably doing it differently. If this is something that is of legislative interest, I I could ask some of our members how they are handling that. If they're asking the employees to use their PTO, or if they're doing some type of administrative leave with pay. I'm guessing it might be somewhat if what's in their collective bargaining agreements. I don't have a good answer to that question. So.
Madam Chair, if you could get more information, I'd appreciate that. Thank you.
Thank you. Next, I have Senator Hayden, and then we're going to follow up with testifier Corey Brown from Sanford Health. So Senator Hayden.
Good. Well, thank you, Madam Chair, and thank you, Ms. Krinke, for your thorough and excellent presentation. I just have kind of a couple of questions and maybe a statement. I'll start with the statement first. We are also concerned about the $50 million, and we know that a lot of it was slated to go to hospitals in particular, but there was a lot of outreach conversations and frontline health workers and clinics that we thought that money would go out. So we've been having ongoing conversations. As you well know in your presentation, and everybody knows that prevention is probably the best thing that we could do in order to keep those beds open and to try to bend the curves. I think that we know that ad nauseum. And so I represent districts, and many of us where people need trusted advisors and people to help them understand that maybe there's language barriers, et cetera. I think about some of the high-rise, senior high-rises in my district, and that if the infection goes through one of those, that could overwhelm the system in of itself. So I just want to make sure that we know, and we are pushing the Department of Health to get that out to do the prevention work as well, so that the hospitals aren't inundated. The second question, Madam Chair, Ms. Krinke, if I may, it kind of piggybacks onto Senator Marty's question about workman's comp. One of the things, if you walk through the issue, you said that you wanted to ensure that it just wasn't someone that got sick in the normal course of the matter, the common cold or some other flu that they needed to show that they had COVID-19. However, we're hearing that we got real testing issues and supply issues depending upon where they're at. So they may present with symptoms that we don't know what it is and not have the necessary testing supplies to do so. So I wanted to make sure that that got put on the table. I think that workman's comp is a question that we really need to have with frontline workers, but I would hope that we would continue to work awfully hard to make sure that all of those workers, regardless if it is the maintenance worker who's cleaning the room, all the way to the physician or anesthesiologist or vent worker, whoever might be able to get that, or heck, the primary care physician, one of those we got on the line today, that we would be able to make sure that they get the testing that they need. And with lack of testing supplies, I'm worried that they may not get that.
Ms. Krinke?
Yes, Senator Hayden, thank you for that question. Regarding the first part of that, total agreement that our federally qualified health centers should be eligible and get some of this $50 million. They're doing a great job, and particularly reaching out to some of our newer populations here in Minnesota. And we recognize your comments that if this gets into one of the senior high rises, or it could move potentially very quickly. So total agreement with your first comment. Regarding your second comment, I was in discussions with some of the government relations folks from SEIU, and they specifically asked me how we could craft the language in workers' comp to make sure that it did include cleaning staff that came into a room or food delivery services that came into a room. And regarding the testing, I think there's going to be language in there that says if a physician agrees that they think this person has COVID-19. We just didn't want the language to be so open that anyone who was sick could say they had COVID-19. We just wanted it to be a little tighter regarding direct correlation with a patient or direct correlation with really having COVID-19.
So, thank you. Anything further, Senator Hayden?
Oh, sorry, I was on mute. Madam Chair, there may be some in the future, but I know that we're on a tight timeline.
Thank you. And I do have Senator Pratt, and then we're going to move to Mr. Brown because we are running out of time. Members, you can always send your questions directly to Ms. Krinke or get them to Ms. Strand, and she will get them to Ms. Krinke. So Senator Pratt, and then Mr. Brown, if you could make sure your video is on, we'll go to you next. Senator Pratt.
Well, thank you, Madam Chair. I'm going to take a little bit different line of questioning here. we talked about the fact that we're moving the peak out, and I don't know that we have a clear understanding of how high that peak will be. But we get a lot of statistics, and I'm wondering, what is the critical statistic we should be looking at? Is it number of ICU beds being used, number of ICU beds available? Is it truly the cases? I mean, I'm just kind of confused. What should we be looking at? What are some of the most important stats to help us along the work we have to do?
And Ms. Cranky.
Senator Pratt, that is literally the million-dollar question. Which model do you use? When does the peak hit? How bad is it? I truly believe our social distancing policy and our stay-at-home policy now is making a difference to flatten the curve. That is what we saw in other nations around the world. So what we're doing now is to push that curve down. I think the experts are saying, I don't know if I dare tell you this, but I don't think the peak is going to hit until probably the end of May. So that does give us some time to get more resources in, personal protective equipment, the ventilators. These are questions for our state Department of Health and the national epidemiologists, and is really beyond sort of my expertise.
But I guess
Thank you, Senator Pratt. Anything further?
Yeah, I guess of all the stats that we're seeing, what are the stats that you follow most, and what should we be following?
Ms. Cranky.
I am predicting that Governor Walz feels the necessity to extend the stay at home for a longer length of time. Looking at what other states are doing, if we look at what Governor Cuomo is doing in New York with everything he's done there are lessons to be learned. And get as much personal protective equipment and ventilators as our state can get. That's.
Thank you, members. Thank you, Ms. Cranky. We're going to move on to.
Thank you, Madam Chair, for this opportunity.
Madam Chair, can I
Ms.
ask one
Cranky.
quick question?
Oh, briefly, Senator Jensen.
Thank you. Yes, Ms. Cranky, I understand from some of my constituents and people that there may be some hospitals declaring that birth partners cannot be in a delivery room. Specifically, a husband might not be able to be with his wife when she's delivering a baby. Can you speak to that issue? Is that a confirmed thing, or don't you know?
I have not heard that until today.
Okay, thank you.
So thank you. Mr. Brown is the Vice President of Government Relations for Sanford Health.
Senator Benson.
If you could keep your comments to about 5 minutes, and then we'll go to member questions again. Thank you.
Hey, Senator Benson, but I had a question for Mayor Cranky.
Oh, I think Ms. Cranky has gone offline. Bobby Joe, is that something we can get more directly to her after the hearing?
Yes, because I thought one of the things that, well, here's my question, and we can get it to her. I thought a part of the $200 million bill that we passed, that there wasn't a provision that allowed for the hospitals to purchase, I think it's either ventilators, because there was a concern that they could potentially use either ventilators or respirators in the future, and they were not allowed under our bill in order to make that purchase. Am I right or wrong about that? Maybe you can answer that, and then we don't need.
I can answer that. So Chair Liebling and I agreed that we would focus on the things that would be directly consumable by patients or that were only for COVID response. So if you needed to convert an emergency department into isolation or negative airflow space, that would revert to emergency department work. Chair Liebling had expressed some concerns that hospitals might be enriched by this program. And so we tried to keep it pretty narrow, but it is, so if they need to house nurses in hotels for quarantine purpose or to protect their families, the hospitals can use the money for that. If they need to buy protective equipment when it comes available, they can use the money for that. So given how much money is available and the demands on that, I think that we did the best we could with things that were immediately usable by the hospitals as they converted spaces for COVID benefits. One of the other things we know that of the last set of money that went out. Governor Walz did make some money available to purchase ventilators. Now, I know there are hospitals who months ago got in line to purchase ventilators and are still waiting to get those. And so I think the purchase of those critical pieces of equipment will be emerging in the next couple of weeks if we can build up our supply chain. So, Mr. Brown.
Thank you. Senator Benson and members of the work group, I just want to make sure my audio works and you're able to hear me.
Yes, we
Terrific.
can hear you.
Hey, thank you for the opportunity to testify today. As Senator Benson indicated, I represent Sanford Health and the Good Samaritan Society, which I think maybe brings a unique perspective to this conversation, and the fact that not only do we work in the acute world on the hospital side, but with our merger with the Good Samaritan Society about 1.5 years ago, we also represent a significant portion of long-term care and post-acute services, especially in western and northern Minnesota. Much like the others that you'll hear from today, we are weeks into preparing for the COVID-19 response here in Minnesota as well. The state, the legislature, and the governor have all been very proactive in preparing for this virus to the extent they can, and I think should be commended for the many steps that have already been taken. However, there's one topic that I would really like to focus on today, and that is workforce. Sanford's combination with the Good Samaritan Society has given us the opportunity to work into 22 different states across their network of post-acute services. This also means that we've been dealing with this crisis on the front lines in states like Washington for many weeks. And a reoccurring theme that continues to surface is the lack of workforce during these surges. Despite all of the preparation and attempts to have proper PPE and inventory to work on the issue of beds, we always come back at the end of the day, and one of the main focuses and troubles that we have is really the issue of workforce. I understand that it may not feel like that today in Minnesota. After the state had imposed a ban on elective procedures, many of the state's healthcare providers have felt the repercussions of that. In our system alone, many of those frontline workers and physicians and nurses have had to have their time flexed down, although we have not had any layoffs. However, I need to urge that this is the calm before the storm. Much like a hurricane, we know that the full impact of that storm is coming, and it'll come very soon. In fact, today at Sanford Health and the Good Samaritan Society, we are in the process of upskilling workers to make sure that they can utilize their talents to the fullest extent of their training and licensure. However, when we see the impact suffered by some of these facilities, we know that this upskilling and those efforts will not be enough. Just take a look at Kirkland, Washington. In that nursing home, they saw 50 of their 170 employees infected with the COVID-19 virus and disease. And while we may not see numbers quite like that given some of our preparation, it's not unrealistic to think that the infection rate could be at least 20% generally, especially in some localized areas. The local options to replace the workforce are simply not enough. Despite all of the preparation and positive actions that Minnesota has taken already, there is still one major area that could be very easy to fix today. All of those efforts to secure PPE and expand beds will be worthless without the needed doctors and nurses. On March 24th, Secretary Azar of the Federal Health and Human Services Department wrote to all of the governors asking them to issue waivers to allow healthcare workers that are licensed and in good standing in other states to practice across borders. Minnesota has not relaxed those requirements. Moreover, when you look at the requirements for most of the licensure categories, it's ironic that the surrounding states have very comparable requirements either for physicians or nurses, etc. As we're making the last minute preparations for the major influx of COVID-19, we are urging Minnesota to take some of the same actions that dozens of other states have done and to allow for waivers for these out-of-state licensed doctors, nurses, healthcare providers that are in good standing. Not only will this help us with the physical presence in the facilities, but as Senator Rosen indicated, it's also a critical component to telehealth as it broadens our capabilities to tap another pool of healthcare workers that could serve the citizens and residents of Minnesota. The simplest mechanism would be for the state to enact the Emergency Management Assistance Compact, or the EMAC. For the healthcare workers and the residents of the state, I would strongly urge you to consider these measures. Thank you for your time.
Thank you. Members, we'll take a couple of minutes for questions for Mr. Brown, and then I do have two other testifiers before we move on to long-term care. So remember to use the hand raising, and Ms. Strand will monitor. Not seeing anybody on the list, so just giving a couple of minutes. All right, Mr. Brown, I want to thank you. Ms. Rebecca England is next on the list. If we could have staff or Ms. England open up her video. Thank you,
Hello.
Ms. England. Ms. England is with the Minnesota Emergency Nurses Association, and we'd like to hear from you for a couple of minutes. Nurses are important in this battle as well, so thank you for being here.
Thank you, Madam Chair and members, for the opportunity to speak here today on behalf of the Minnesota Emergency Nurses Association. 2020 is the year of the nurse, Florence Nightingale's 200th birthday, and we find ourselves in the middle of a pandemic. Emergency nurses are known for providing a calming presence during chaos and easing their patients' fears. They are brave, courageous, and resilient. We need to stay healthy to continue providing this care for your families, friends, and maybe even you. This is how you can offer support: continued mitigation of exposure risks and recommendation, continued efforts to obtain additional medical equipment and supplies, supportive statements to the nursing community, continued public education regarding the transmission of the virus and safety measures. I want to take a moment to thank the emergency nurses. You are vulnerable, and we hear you. You are anxious, and we hear you. Yet with all of this, you push through and are on the front line every day providing compassionate care. You are healthcare heroes, and the Minnesota Emergency Nurses Association stands beside you. In the spirit of Florence and her lamp, I would like to leave you with this: sometimes the brightest light comes from the darkest places. Thank you for all you do to support the emergency nurse.
And thank you, Ms. England, and I think I speak for everybody on this call. My sister-in-law is an ER ICU nurse, and what we're about to ask people to do is unimaginable for those of us who aren't in the hospital. And so as much support as we can give you, we'll be there. So I would encourage folks watching this, reach out to the nurses you know, and just give them an attaboy once in a while, because they're gonna face some really tough things. Right now, they're facing step down hours and possible furloughs, and then they're going to be asked to come in full force. And so we appreciate, Ms. England. Thank you for being here today.
Thank you.
Next, Ms. Mary Turner with the Minnesota Nurses Association. And if we can make sure her video is on. And I just want to thank everybody for your patience as we're figuring out this technology. So give us pointers what we can do better. Thank you.
Okay.
Ms. Turner, we don't have your video yet, but we do have your audio.
Okay. Good afternoon, Chair Benson and members of the committee. My name is let's see here. Let me press that. Okay.
Thank
My
you.
name, of course, is Mary Turner, and I am a registered nurse on a medical ICU COVID-19 floor at North Memorial Hospital. I'm also president of the Minnesota Nurses Association, and I want to thank you for the opportunity to address the hospital response to COVID-19. The 22,000 nurses represented by MNA are on the front lines of this global pandemic, as we all know. Every day, nurses put themselves and their families at risk in order to take care of COVID-19 patients and protect the public from further spread of this virus. And every day nurses are being asked to do so some are being asked to do without protection to prevent them from getting the disease. We appreciate and understand that these are unprecedented times. We know that there are issues with the PPE production, and the shortage of tests and reagents are being felt across the country. And just to clarify, we are in the ICUs and all around, we are reusing our N95 masks more than just one shift. Just so you know, I will go tonight and I will have my N95 and my shield in a paper bag with my name on it. So we are rationing it and trying to use it as wisely as possible. But we also know that there are things within the hospital's control that could be implemented immediately to protect healthcare workers. To this date, the simple requests of nurses have been denied. So we are turning to you, the legislature, to help protect us. These actions include require hospitals to distribute the PPE that they currently have. While we understand that there is a shortage of PPE, we know that many hospitals are withholding the equipment they have now because they're concerned about saving it for the future. If nurses do not have proper PPE now, they will not be around to care for the future wave of COVID-19 patients. We will also continue to increase the spread of the disease as unprotected nurses will unknowingly pass the disease on to other patients. Because as you know, we don't do social distancing when we're taking care of our patients. We're within inches of them. 2, we need to allow nurses to take showers after their shift and provide them with clean scrubs daily. The simple ask of being able to clean ourselves off or throw out soiled scrubs is being denied by many hospitals. As a result, nurses are forced to bring those soiled scrubs out into the public, into their homes, and potentially exposing their families to COVID. Lastly, train nurses who work in low census units, such as operating rooms, to care for COVID patients. Right now, many of my nurse colleagues who work in elective procedures are being threatened with layoffs, and at the time we face a global pandemic. Instead, these nurses should be trained to help diagnose, treat, and fight this virus. There are many more things that nurses could be done to keep us and our patients safer. However, 2 minutes isn't enough to capture it all. We are at war. We are the nurses. We are on the front line. We head into the hospitals every day with what little PPE we have. And that's our armor. But you know something? We're ready to do battle in this virus, knowing that the patients and the public is why we became nurses. Please, we ask you to consider our uniform standards for hospitals. While there are a lot of unknowns, we know these actions hospitals could be taking now to protect nurses, our families, and our patients from the spread of COVID-19. Thank you.
Thank you,
Mary,
Ms. Turner.
Mary, this is Paul Gazelka. We're going to move hell or high water to make sure that you guys are taken care of. You're on the front lines. Having safety measures in place, we know is critical. Making sure, frankly, that those that themselves get COVID-19, that work comp covers them. We get it. I hear you. I have a daughter-in-law that's a nurse practicing right now in one of the hospitals up here. I have a number of nieces that are nurses in the metro area. And like I said, we're going to move hell or high water and make sure you guys are taken care of. Thank you so much for all the work that you're doing.
Thank you, guys. Thank you.
Thanks, Mary, for being here. Briefly, questions for Ms. Turner? I see Senator Pratt's hands up. If you could unmute, Senator Pratt.
Yeah, thanks, Madam Chair, and thanks, Mary, for your comments. I'm not a healthcare guy, so I'm going to ask a pretty basic, naive question, and that is, understanding you probably can't reuse the mask, but are there any of the PPE that is being reused and sanitized, washed, whatever?
No. Yeah.
Ms. Turner.
Yes. Like it said, the N95, the gold, that you're treating like gold, we are reusing that. I will go tonight on my floor, and I've got my paper bag that has my N95 that I used the other night. It also has my shield that when I come out of an isolation room, I wipe that off. And we are going to use that mat. We use those masks until it doesn't fit properly, and then we get a new one. But we are using them multiple shifts because we are already having to be rationing this. Gowns and gloves, that the gowns get laundered. The gloves we still have, a good supply of, but it's those shields. I do know that we have something called a PAPR. The hoods, we're running low on those. I don't know if when I go in, we've got like 6 positive intubated patients on our floor tonight. And I don't know if there's enough PAPR hoods. There wasn't the other night. I'm a little concerned about not having my own PAPR hood, but every nurse has got their little baggie that's got their supplies that they use shift after shift.
Wow.
Thank you. Anything further, Senator Pratt?
And the fact that the thing is, it is dangerous. This isn't the way we were taught in school. This isn't the ideal way to use our protective equipment, but it's what we're having to do right now.
So thank you. And then Senator Jensen, Senator Hayden, and then we're going to move on to long-term care.
Thank you, and Madam Chair, and thank you, Ms. Turner, for testifying. A question for you. I have numerous constituents and some non-constituents just contact me indicating that they may have access to N95 masks, but they may not be approved in terms of the manufacturer of those masks or the exporting city. Do you know anything about that? I mean, are we potentially holding to too high a standard and in so doing, not getting you and your colleagues equipment that could be very, very useful? And while it may not meet the exact standards, they still would be N95 masks. Do you know anything about that? And what would your thoughts be in that regard?
Ms. Turner.
I thought that the CDC was saying that you could use, you have the medical N95s and then you have the construction N95s, and that the both could be used. And I'm on the governor's task force, and we were just yeah, my people are saying we'll take them, those N95 masks, and when we did our drive and we collected 80,000 masks, we were getting both kinds, and we were delivering them to the state stockpile. And the state actually has the CEOC will take expired masks also, and I believe that the task force has got one of their groups that is looking at all these different things and assessing them. So I think it's possible. I can't tell you right this second which work group is working on that, but that would be Jan Malcolm, Commissioner Malcolm, that would be able to answer that question.
And
right,
members, there is a point person at the center who's responsible for PPEs, and my office has that information. So if you have somebody who has PPE, we have a person you can get it to at the center. Okay. And Senator Jensen, anything further?
No, thank you.
Okay, then next on the list, Senator Hayden.
Well, good. Well, thank you, Madam Chair, and thank you, Ms. Turner. I share with Senator Gazelka that we have to do better and we have to work harder. And I would suggest to you that certainly you can use any of us as a resource, that if there are situations in which you feel like hospitals aren't doing the things to keep nurses safe, you're not able to get the right equipment. I don't want to open up a can of worms here, but I certainly think that we would want to know that and try to help figure out a solution for you. I guess my question piggybacks on Senator Jensen's as it relates to the type of equipment. I guess my concern is if you're using your N95 mask multiple times and trying to figure it out, how safe is that? At what point does it become a detriment to you to be able to reuse that? And how do we figure that out? I see people walking around the community with bandanas on their mouths, and I know that isn't going to do much for them. At what point does that piece of equipment become not useful and you might as well not have a mask on at all?
And Ms. Turner?
When I will go and get a new N95 mask when the seal can no longer stick, or like if the ear pieces Because what's happening more is the earpieces are getting so lax that it doesn't fit on my face. Or if like the metal thing that you clamp a little thing to make this tight seal. Okay. And I've used my mask for one shift. I'm thinking that if I were to work full time, it might last a few days. I haven't worked enough yet to be able to say how long my mask is going to last. What I do have down in front of it is a shield, and that gets wiped off and before I even take that N95 mask off. You know what I mean? So like I said, it is not the ideal, but to circle back also to what Dr. Jensen had said is that we have nurses that want to bring in these other kind of masks, these more construction kind of masks, and so far not all the hospitals are agreeing to that. And so they need to look at the guidelines to free up to be able to bring in any kind of N95 mask that we've got. We will appreciate. So.
Okay, thank you. Members, I'm going to try to move on. We want to respect a 2:30 stop time. So if I could ask Dr. Emily Dowling, Vice President of Medical Operations for Home Care Services with Allina Health and President of the Minnesota Association of Geriatrics Inspired Clinicians, if you could fill us in a little bit on what long-term care has had to do to get ready. And I'm not seeing her. Bailey, if you could help her with video.
Hello, can you hear me and see me?
Now I can. Welcome.
Hi. Thank you so much for having me, Senator Benson. This is a privilege to be here speaking on behalf of long-term care. I'm a geriatrician who's been practicing in long-term care for about 10 years now. I want to first start by just commending all the long-term care facility partners that are out there. They are working incredibly diligently and urgently to try to protect their residents. And they've been diligently working to implement visitor restrictions and to screen their staff to try to prevent those who are infected from coming in contact with their residents. I wanted to specifically for you talk about what I think are some of the big issues that long-term care is facing here. And they're going to be in line as I've listened to a few of the other speakers and the concerns that they have had. One is reducing the risk of exposure to our high-risk seniors that are living in long-term care. And we've started that process with restricting visitors and trying to monitor staff who are coming into long-term care facilities. However, the next level of reducing exposure really is around our healthcare workers and ensuring that those healthcare workers are protected and not exposing other residents within the facilities. Secondly, we really need to, when there is a case in long-term care, not every facility has the appropriate PPE. Again, same PPE issues. Many of our facilities are small in the community, and the way the supply chain is working is that if you haven't had to access a lot of PPE in the past, you are not being prioritized to acquire it. I know the state is working very hard through MDH to have that supply available, but that may not be possible going forth. Now, hearing there are today 47 communities that have COVID in them. Because of that, I strongly believe that we need to start thinking and planning to have some sites that we could transfer COVID patients from their community short-term to another community where they could safely be managed, where the staff is trained appropriately in use of potential personal protective equipment, and where they have the supplies that are needed. The third issue with the nursing facilities is ventilation, and many of them do not have good ventilation in order to help reduce the risk of exposure to other residents or to the staff. And that's different, a lot different from our hospitals often. And so having a place that we could cohort or move these residents short term to reduce the risk of exposure could help dramatically. The second issue that I wanted to raise for your awareness is around testing availability in long-term care. And you heard about testing availability before, and this is a national issue. In long-term care, this is very critical for early identification of outbreaks and early implementation of the processes to prevent spread throughout a community. And without that testing, it's very challenging. And we have had challenges getting tests for patients that we think need to be tested. The prioritization list of inpatients, healthcare workers, and long-term care, although it is a prioritized population, has sometimes been a level, the prioritization has been in that order, and long-term care has not always had the testing so far that it has needed in order to identify outbreaks and manage them well. So anything that can be done to help support funds and development, getting the supplies that were described by the MHA representative for testing for viral media and swabs and reagents, we need that desperately. And then the final thing I wanted to talk about is the grant funding. And there's a lot of, we've been involved in applying for some of the emergency initial 50 million funding, have not heard back on if that money, when it will be decided and how it will be released, or the grant application that has not been posted for that next 150 million. We're making decisions as health systems to move forward for the community good, to plan and make changes because we know that we need to do it. And we're acting in good faith that we hope that some of that money will come to the facilities as well as health systems, but it's not clear at this point. And with that, I'll pause, and I just again want to commend all of my colleagues in Leading Age, Care Choice, care providers for the great partnership and work that they're doing.
Thank you, Ms. Downing. And members, remember to raise your hand if you have a question. I do have a question, Ms. Downing. I had heard that tests were not available to be performed at long-term care facilities, and that there was recommendations that suspected cases be taken to a clinic or a hospital for testing. Do you know if that has changed, or is that something that still needs to be elevated?
Tests are capable of being performed at long-term care facilities. The true reason is really the access to the tests, the swabs, and the media. So almost every facility has the capability to have the test done, but they're being told by labs that there are no tools to do those tests. And so those facilities then are deciding to send them to the emergency room to try to get them tested. And if they're not sick enough, often the emergency room doesn't know that they should be tested because they're from long-term care, and they're being discharged again without a test.
Okay. So it sounds like the concern that was raised has not been resolved, in part because of supply, but maybe there's some system improvements that we can do even without supply concerns, because cases in long-term care facilities become particularly problematic for the rest of the healthcare system. Seeing no hands raised, and I don't have any notes from Bailey, I want to thank you, Ms. Downing, and all the folks at long-term care. I know that you're coordinating across systems, you're training your staff. Again, PPE is a challenge for the long-term care facilities. I just want to thank you for being willing to care for the people who are most at risk in this pandemic. And you work so well with the hospitals. I get a little window into the level of communication that you're doing with the rest of the healthcare system. You are really a key piece to how Minnesota is going to perform. And I want to thank you very much for being here. And with that, Senator Gazelka, that is the list of testifiers and public who asked to be part of this hearing. So I'll turn it back over to you. Thank you for letting me do this today.
Yeah, Senator Benson, I really appreciate that you were the moderator here. You're the expert, and it meant a lot. And thank you for the testifiers that spoke. I wrote down a number of things in my notebook that I'm going to circle back to the governor. The fact is, the Senate has Republicans and Democrats working together, and we're going to work with the governor and the House to beat this thing. That's our commitment to you. And so some of the things I wrote down, one is takeaways, 4 or 5 of them. One is that we need to work on an emergency assistance compact for people coming out of state. If the governor does that as an executive order, when it ends, it ends. And so it doesn't have to be political. We just need to make sure that we have resources there if there is the spike that we think there might be. The second one I took away as a takeaway is we have to find financial solutions, particularly for rural hospitals. They made the commitment to provide the resources that we need. That was a real sacrifice for them, so we have to figure out what we're going to do about that. A third one I have is just underlining hospital workers need to know that we have their back, and we are going to find a work comp solution there, I believe, very, very shortly, but also the supplies that they need just to take care of themselves while they're on the front lines. Those people, fire, police, that's what we need to pay attention to. And finally, listen to the long-term care provider. We need to figure out what to do when somebody has COVID-19 in a long-term care facility. How do we make sure that it doesn't spread to the whole facility? So those are all really, really helpful ideas. I hope this is a good format. We're trying to figure out how do we listen to people and all get on the same page, and then how do we work with the governor to find success here. And so in the beginning, as we started, apparently the Facebook connection didn't record what we had. And I just want to mention to people that we are doing working groups on a regular basis. It's 11 senators, 5 from each, or 11 total, 6 from the Republican side, 5 from the Democrat side. In this one, we had Senator Benson, Chamberlain, Champion, Cohen, Kent, Marty, Pratt, Rosen, Hayden, Jensen, and myself. And so thank you for that group of people. We're in this together. We're gonna defeat this. And finally, I want to talk about what we're going to do tomorrow. We're going to have a hearing at 11 o'clock. This will be on the significant economic impacts of COVID-19 and what is the current state of Minnesota's businesses. There's some things that we can do about that. Again, we're going to be listening to ideas that they have, and hopefully we're going to be able to implement some of those ideas to stand with those that whose livelihood has been impacted by this virus. So, and then we'll do some more next week. But tomorrow it's at 11 o'clock. Again, thank you for everybody that joined us. If you have ideas to help us make this better, we certainly want to listen. And with that, we're done.